looking for. Yeah. Today we are having a webinar on International Childhood Cancer Day. The day is not today, it's actually tomorrow, but we are commemorating it today by creating awareness among the healthcare workers on this issue. So I'll be a moderator for the day. My name is Dr. Joyfrida Chepchumba. I'm the program officer in charge of treatment, palliative care and survivorship at the National Cancer Control Program. So I'll just highlight a few policy perspectives and priorities for childhood cancers before I bring on our pediatric oncologist for the day. So the International Childhood Cancer Day is a global collaborative campaign to raise awareness about childhood cancer, its unique needs, and to express support for children and adolescents with cancer and the survivors and their families. So it's celebrated on the 15th of February every year, and it started in the year 2001. So the theme for this year is that better survival is achievable through their hands. So this theme has been running for the past 3 years. In 2021, we had better survival is achievable through my hands. Last year, we had better survival is through your hands, and then now this year is through their hands. So the focus is on the parents, the teachers, the caregivers, generally the society that surrounds these children. And there's various roles that they can play. They need to be alert to the children's milestones and the complaints. They need to seek medical attention when a complaint persists and to adhere to the doctor's guidance. We know, especially on the third point, we have a lot of issues where some families will abandon treatment for the children, and that's actually a major issue that needs to be addressed. So generally on the epidemiology in Kenya, we have around 2,000 new cases for children every year. And the survival rate is given at about 19 to 30%, mostly because of the late diagnosis, the late presentation to our facilities. But when you see in high income countries, you'll find survival rate is up to 80%. So we have some way to go. So in terms of categories of the childhood cancers, you'll find we have hematological cancers and solid tumors. So the most common types of the hematological cancers are the acute lymphoblastic leukemia, the acute myeloid leukemia, chronic myeloid leukemia, and the lymphoma. Solid tumors, we have the Wilms tumor, the sarcomas like rhabdomyosarcoma, germ cell tumors, neuroblastoma, retinoblastoma, and brain tumors. So globally, we have around 400,000 cases annually, and the common childhood cancer is actually the acute lymphoblastic leukemia, followed by brain tumors and lymphomas. And the picture in Kenya is actually quite similar to the global picture. The most diagnosed pediatric cases in Kenya are ALL at 16%, non-Hodgkin's lymphoma at 14%, Wilms tumor at 9.1, Hodgkin's lymphoma at 7.2, and brain tumors at 6.8. That's according to GloboCan 2020. So some of the reasons for poor childhood survival rate, first of all, there's lack of awareness and information on childhood cancer. And this stems all the way from the society to the parents, to the healthcare workers. They don't know what exactly to look out for. Then there's delayed or wrong diagnosis. A child is delayed in the treatment for a different thing, and yet they could have been referred up for better diagnosis. Then there's lack of access to quality, cost-effective, essential medicines and treatment. We know the treatment for children is different from adults, and it needs to be tailored as such. Then lack of access to trained healthcare providers. There's weak health infrastructure, there's obstacles to accessing care, abandonment of treatment, death from treatment toxicity, among others. So Dr. Meadow will discuss how these conditions will present. So there'll be such things such as the pallor, there'll be lumps or swellings, especially they can be painless and without fever or any other sign of infection, unexplained weight loss, eye changes, abdominal swelling, headaches and vomiting, limb or bone pain swelling. So a key message is that actually the child may be asymptomatic and the only abnormality detected is during a routine visit. Screening is generally not helpful for childhood cancers apart from retinoblastoma, but cure is possible for more than 80% of children. This survival rate in children is highly attributable to early detection. So the diagnosis of childhood cancer requires a high index of suspicion among the healthcare workers, good clinical skills. You need to know how to do a thorough workup, history taking, a good physical examination. Some of the investigations that may be used to make a diagnosis can even just include a lab workup. And the treatment will depend on the type of cancer, extent of the disease, age of the child, and this will be done through a multidisciplinary team, which will provide a treatment plan. Based modalities will include surgery, radiotherapy, chemotherapy, hormonal and targeted therapies, bone marrow transplant, immunotherapy. Supportive care is also very critical in the management of childhood cancer. So palliative care needs to come in, infection prevention, symptomatic management, treatment of oncologic emergencies, psychosocial support. And in this, it's both support for the child, for the parents or the caregivers, and also for the siblings. Sometimes we forget the siblings of these children, and this is a big gap. The siblings really get affected when their sibling is unwell. And there's the spiritual support. I think as a country, we all recognize the importance of that. We all know palliative care is a key component, and it's initiated at the time of diagnosis, and it's done by a palliative care team. There's a specialized team, I believe in every facility. By now we've created awareness on palliative care. There must be a specialized team in palliative care handling this. That shows the multidisciplinary aspect to management of childhood cancers. So everyone has a role to play: the nutritionists, the mental health practitioners, radiologists, spiritual counselors, the pharmacists, rehabilitative officers, social workers, surgeons, pathologists, oncologists. Everyone has a role to play. So there's a childhood cancer assessment tool that as healthcare workers, you can use it in case there's a child in front of you and you'd like to know, is there more to this child than I'm seeing? Some things to look out for is maybe fever for over 7 days, persistent headache, bone pain, some nodes, neurologic symptoms, visual disturbances, masses. And apart from all this, there's also the milestones that a child should have achieved. We should not take it lightly when you see a child is not achieving certain milestones. There could actually be a problem. So we need to be very keen when these patients come to our facilities. So if you find any case, what do you do? First of all, if you've gone through this assessment tool and you can see some of these signs are there, please refer the patient directly. It does not have to go through all the channels of level 3, 4, 5. Just refer directly to KNH, MTRH, KUTRH, or Kisii referral hospitals. That is among the public facilities. And among the private facilities, we have Gertrude, Nairobi Hospital, Aga Khan, and Kijabe Mission Hospital. This is another note on medical insurance. We know the out-of-pocket expenditure is quite high in our health system. So we encourage parents to enroll for NHIF immediately, even right now when everyone is just okay, before any condition is discovered. So as we conclude, childhood cancers are broadly classified as hematological and solid tumors. Childhood cancer diagnosis requires high index of suspicion and good clinical skills. So Kenya is a part to this global WHO Global Initiative for Childhood Cancer, which was launched in 2018. And our goal is by 2030, we want to achieve at least 60% survival for childhood cancer globally and reduce suffering for all. So remember, the survival rate in Kenya is at least 30%, which is not very good. So we'd like by 2030 to achieve 60%. So among the policy documents which the Ministry of Health has launched that will help us in achieving this, we have the Kenya Cancer Policy 2019 to 2030, the Cancer Control Strategy, which expired in 2022, but there's a new one being drafted, and there's a lot of emphasis on pediatric cancer. We have the screening guidelines, which also mention about the screening for retinoblastoma, and the National Cancer Treatment Protocols, which also speak to pediatric cancer. So something that you can take away is these e-learning platforms. We have the M-Saratani app, which is on Google Play Store. You are able to have some content on cancer, the various types of cancers, including pediatric cancers, and their CPD points awarded, as well as certificates. Also, the MOH Virtual Academy, you can find the content under early diagnosis of cancer course for primary healthcare workers. So you can read more on pediatric cancer and how it can be diagnosed. So on the way forward, the ministry is working to ensure NHIF cover for children is still unmade. There's already a proposal that was forwarded to NHIF so that pediatric cancers are covered fully. Also, we are looking to create quality and centers of excellence among the level 6 facilities. Also, to increase clinical trials and clinical research to inform best practice. Also, we are working on improving access to rehabilitative commodities and treatment assistive devices for children. Also, sociocultural, we'd like to create awareness on these children. Most of the time will still need to be reintegrated into the society. A good number of them will survive. So how do we reintegrate them into the society, into the school, back to their normal lives? That's also something we are working on. So in conclusion, better survival for children with cancer is achievable. We have a goal by 2030 to get 60% survival rate for our children. High index of suspicion is essential. Early detection saves lives. Pediatric centers of excellence are required, and we need to increase the number of pediatric trained specialists. So that is the end of my presentation on the policy perspectives on childhood cancer. So for any questions, you can put them in the chat box. We will address them shortly. So next up, we'll have Dr. Omedo. Dr. Omedo, hi, are you ready?
Yes, I'm ready. You can put up my slides for me, please.
Okay. Okay, so just a few highlights. Dr. Deborah Omedo is a pediatric hematologist working in Kisii Teaching and Referral Hospital. She did her fellowship training at Mulago Hospital in Kampala, Uganda, in collaboration with Baylor College of Medicine and Texas Children's Hospital, USA, in 2020. She takes care of children with cancer and blood diseases. Her vision is that all children in Kenya will have access to quality healthcare, regardless of their location and socioeconomic status. And she was awarded the Mashujaa Day Medal in the year 2020. So welcome, Dr. Deborah.
Thank you. So as Dr. has already mentioned, tomorrow, 15th of February, is the International Childhood Cancer Day, where everywhere in the world we commemorate childhood cancer. So I'm going to give a presentation about how to empower caregivers, parents, children and the community at large to be able to detect cancer early and to have a high index of suspicion. So cancer is a group of diseases that causes abnormal cell growth with the ability to spread to other organs. So as these cells become abnormal, they start multiplying in a very vicious way. They do not die in the normal process, and they begin to destroy the tissues around them and move towards other organs. Next, please. So usually cells divide in an organized way, but when the cancer, when they mutate into cancer cells, they divide very abnormally. They don't die the natural death of apoptosis, and then they begin to destroy the tissues around them and spread to other parts of the body. Next, please. So the month of September is the month of September is the Childhood Cancer Awareness Month. So for the whole month of September, there is the activities all over the world to try to make sure there's more cancer awareness. However, the International Children's Cancer Day is 15th of February, that is tomorrow. So the theme for childhood cancer, unlike other cancers, is gold. The golden ribbon is the ribbon for childhood cancer. And so during International Cancer Days for children, we wear gold or yellow, yellow and black, or just yellow alone. The gold color is what is the theme. So unlike other cancers like breast cancer where they use the pink ribbon, for children's cancer, we have the gold ribbon. And so that is the ribbon we use to identify childhood cancer. And when we have themes celebrating children with cancer, we make sure that we decorated the places with the yellow or golden ribbons. One of the warning signs for cancer is bruising. Any bleeding from anywhere, even if it is nose bleeding, vomiting blood, bleeding from the rectal region, or bruising, just such as this, where you can see there is blood under the skin. That can be a sign of childhood cancer, especially the acute leukemias. They can present with bleeding, because very frequently in acute leukemias, you can find the child bleeding, the platelets may be low. Then the other warning sign is pallor. We know in Kenya there are so many diseases that can cause pallor. We know that many children already have iron deficiency anemia. Malaria is quite prevalent in most parts of the country, especially for us in the western region counties. And so it's very frequent for us to assume that the child is pale because of malaria or iron deficiency anemia. But it's always important for us to be able to take a peripheral blood film for each and every one of these children who presents with anemia. Because if it is looked at properly, they might actually find that there are blast cells. And these blast cells could be a sign of leukemia. And and once we detect that early enough, leukemia is a treatable cancer. About 80% of children can be cured from leukemia. And so whenever we see pallor, yes, we know that they're the usual diseases, but let us always think extra. That it could actually be cancer, and especially the leukemia. Then bone pain. If a child has bone pain, we need to be suspicious. Many times we think when there's bone pain, we think, oh, these children, maybe they ran a lot at school, maybe they had a very vigorous physical education. And so sometimes we take it for granted. But if it is persistent, we have to think about cancer, because some cancers just start with bone pain. Many leukemias start with bone pain. Some of the bone cancers, such as osteosarcoma, and many other cancers affecting the bone can also just begin with just generalized bone pain. So whenever we find children presenting with bone pain, let us not take it lightly, and let us be able to investigate even further. So the other warnings that can, of the signs that can cause the signs of cancer is lumps. Whenever you have a lymph node that is the size of a grape, or just as we had mentioned by the previous speaker, more than 2 centimeters. And especially when there's no fever, there's no associated infection, one has to be suspicious of cancer. Very many childhood cancers present with lymph nodes, some of them including Hodgkin's lymphoma, Rosai-Dorfman, Kaposi sarcoma, the Langerhans cell histiocytosis, and many others can just present with just a lymph node, a grape-sized lymph node. So whenever we see these lymph nodes, even as we rule out other infectious diseases, such as maybe a toothache or a throat infection or skin infection, scalp infection, we should also think about cancer. And we thank God, in the counties, we have had quite a number of pathologists trained, even with a fine needle aspirate, and they can do a fine needle aspirate and see whether it is a suspicious node or not. And once it's found to be suspicious, we also have quite a number of surgeons, even within the counties, who have been trained by the counties. A biopsy can be done, and we can get a diagnosis. And once we find the diagnosis of the cancer, then we are able to start the correct protocol, the correct childhood protocol, and treat the child. As the previous speaker had said, children are not small adults. You cannot use the adult protocols for children. You need to use the pediatric, world internationally recognized protocols to make sure that our children get the best outcome. So another thing is weight loss. You can find a child losing quite a bit of weight, and you can't explain why. As many times in our setup, we think about TB, we think about HIV, but another thing that we need to think about is also cancer. Cancer can also cause quite a significant amount of weight loss, because cancer is a high metabolic state. We can find the child losing a lot of weight because the cells are multiplying so fast. The child may have poor appetite, and that there can be weight loss. And almost all childhood cancers cause weight loss. So whenever you see weight loss in a child, even when you're in the mother-child clinic, health clinic, a child is not gaining weight well, or is flat, or is even losing weight, one of the differentials we have to think about is childhood cancer. Eye signs are very, very important. You can see this child. When you look at the left eye of this child, you can see there's a white mark. That can be an early sign of retinoblastoma. Other eye signs that we need to watch out for are like squints, or even redness around the eye, like in the case of neuroblastoma. So whenever you see something that is abnormal with the eye, do not take it for granted. Have an ophthalmologist review the child and screen for possible cancer as a differential. Yeah, and sometimes even just a squint, it could be a sign of retinoblastoma, or it could be a sign of even brain tumor, and the redness around the eyes can be a sign of neuroblastoma. So whenever you see any eye changes of any kind, always be suspicious. Redness of the eyes, conjunctival bleeding can be a sign of low platelets, can be a sign of leukemia. So whenever you see any kind of eye changes, whether it is the white reflex that you can see here on this photo, or a squint, or redness or swelling of any kind, because you have even rhabdomyosarcoma of the eye muscles, this can be a sign of cancer. Never take it for granted. Let it be checked and verified to make sure that it's not cancer. Abdominal swelling. So many times, some cancers appear so innocently, and you just notice just a slight swelling while bathing the child. Many nephroblastomas, one of the commonest solid tumors in Kenya, can be noticed like that. Sometimes it is painless. You just feel as you're bathing the child that there's something swollen, abdominal swelling. Many nephroblastomas can be detected like that early enough. Neuroblastomas as well. Many Burkitt's lymphomas have also presented with abdominal masses, and many other cancers. So whenever there's abdominal swelling, do not take it for granted. Many times you just say, oh, deworm the child, or maybe let's do an enema and such things like that. Yes, it's true. There can be many other topical conditions, but cancer has to be at the back of our mind. And we need to do imaging. We can even start with just a simple ultrasound, and then later on maybe do the CT scans, and then have a biopsy done. And then if we find it is cancer, we are able now to start the proper treatment of that cancer. So we do not have to wait until the cancer is so huge, when the tumor is so big, or it has even spread to other parts of the organs. Headaches. Headaches are a very common thing. Almost all of us have headaches at one time or another, and there can be signs of many tropical diseases. We know we have malaria that is quite common. In this very hot season, when children are so tired, they get dehydrated and they may have headaches. But however, if the headache is persistent and occurring mostly in the morning, sometimes associated with vomiting or nausea, this can be a sign of brain tumor. And we have been told that brain tumor is actually the most common solid tumor cancer in children. But many times we miss it or discover it when it is too late, when it has already spread to other parts of the body. So whenever there's a persistent headache, especially an early morning headache, sometimes associated with nausea and vomiting, we need to think out of the box. It's not just be the malaria, the typhoid, and the other things that we think about. It might actually be cancer. And that's where now the CT scans become very important. And we thank God that in the counties, more and more people are having NHIF, and they have more and more access to getting CT scans done in time. So let's never hesitate. When there's a persistent headache, this might give you a chance to discover a brain tumor in good time. And when it's discovered well, we have an increasing number of neurosurgeons who are able to do a biopsy, and then we are able to either have the mass removed and also give chemotherapy before and after, and follow up the child. And many of them can be cured. So, but it needs a high index of suspicion from us as the community, as the healthcare workers. So limb pain and limb swelling is very, very common. We know there, especially in the teenagers, there's the osteosarcoma and many other bone tumors affecting the children. So whenever you see limb pain and swelling, do not assume that it is just trauma. You might find that it's actually not trauma. And we have had so many limb and mass of cancers for children. We've had sarcomas, quite a number of sarcomas, the osteosarcoma, and many other cancers that we have of the limbs. So whenever there's limb pain or swelling, make sure a biopsy is done in good time, imaging is done in good time, screening to make sure that it has not spread to other parts of the body, and then prompt treatment of this is done. Next, please. So childhood cancer is curable. In America, for example, almost 80% of their patients get cured and are then followed up as long-term survivors. And childhood cancer is also curable even here in our setup. There are many children we have diagnosed and treated and are now in remission and have been integrated back to school and are doing very, very well. It is very, very possible to treat childhood cancer and cure these children. All that we need is a prompt diagnosis, a timely and appropriate management, and good supportive treatment. That's all that we need. And we can be able to achieve even those levels that have been achieved by countries that are more developed than ours. Next, please. So what are some of the investigations that we do when we discover that it could be cancer? So some of the investigations include imaging, as we talked about ultrasound, chest X-ray, CT scans, MRIs. All those are very important in especially the solid tumors. Then biopsies are important, where the biopsy can be taken for histology and also immunohistochemistry, so that the cancer can be well defined, and then we can put the child on the right treatment protocol and cure them. Bone marrow aspirates are very important and terrifying biopsies, and this can help us, especially with the leukemias. And also sometimes some of the solid tumors like neuroblastoma may spread into the bone marrow. And when we do the bone marrow aspirate, we can be able to discover how far the solid tumor, like a lymphoma or a neuroblastoma, has spread, and we are able to be able to treat appropriately. So even just the normal peripheral blood film, lab tests like a peripheral blood film can give us a suspicion of cancer, especially the leukemias, and then other tests like a hormonal tests, for example, in germ cell tumors, and even the supportive management tests, the hemograms, the UECs, the LFTs, all those play a big role in making the diagnosis of cancer, the uric acid levels, the ferritin levels, and all those. So how do we manage the cancer? Next, please. Yeah. So the mainstay of cancer is chemotherapy. Then we also have immunotherapy. Of course, we need supportive treatment like blood and product transfusion. We remember leukemias are still the most common cancers in children. And so that means we'll need to be able to transfuse the children whole blood, platelets, and sometimes even fresh frozen plasma. Radiotherapy is also important in some of the cancers. For example, in nephroblastoma, in brain tumors, in neuroblastoma, and many other cancers, radiotherapy may be indicated. Even sometimes in some leukemias, when there is CNS involvement, there is need for radiotherapy for the children, even after they have undergone chemotherapy. Surgery is also very important, not only for in the solid tumors, not only for diagnosis, but even for treatment. So in solid tumors, you want the initial tumor to be removed as you continue chemotherapy and perhaps radiotherapy to be able to prevent the recurrence of the same cancer. Then sometimes you might need transplant. We might need transplant because sometimes like a liver cancer, liver cancer, if it is very, it has spread into almost all the lobes, there might be need for removal of all the lobes and replacement liver transplant. In some leukemias, when they recur and the child has gone into remission, there may be need for bone marrow transplant as well. There are sometimes in bilateral nephroblastoma, if both kidneys have been very adversely affected by the cancer, there might be need for renal transplant as well. So we need to also prepare ourselves to be able to do some of those for some of the cancers, especially when they're advanced. Then palliative care is essential for all cases, whether it is early disease or late disease. We should work together with the palliative care team so that we holistically treat this child and the family, psychologically, mentally, emotionally, as well as the physical disease, control the pain, and cure if possible. But even if not possible, cure is not possible, make sure that they're as comfortable as possible, and support is even given even after death of the child. Next, please. So when a child is diagnosed with cancer, the whole family is affected. Everyone, the parents, the grandparents, the neighbors, the classmates, the desk mates, the school children, and they're even putting the pets, can even miss that child and feel so bad. Everyone is affected. Many times, if the mother has to stay for long without going to work, and there's loss of income in the family. And when there's loss of income, you might find the other siblings are not able to get school fees, and so they drop out of school because of their sibling who has cancer, and it can mess up the whole family. So supportive care is very, very important. We need to involve the social workers. We need to involve the community. We need to involve philanthropists to make sure that the whole family is given the right support when the child has cancer. Next, please. So with just these few ways of being suspicious of cancer, you can pick up so many cancers. Like there were just 9 months when I made these presentations after coming from fellowship. But just by having high index of suspicious, we managed to diagnose many acute leukemias, many lymphomas, many nephroblastomas, neuroblastomas, retinoblastomas, osteosarcoma, nasopharyngeal carcinoma, and many other cancers since then. So as they have put the theme that we can cure cancer through our hands as caregivers, our hands as parents, our hands as healthcare workers. Just by having that high index of suspicion, we are able now to notice these cancers early enough and get treatment on time. And once you treat the cancers properly on time with good supportive care, many children get cured. and they're able to reintegrate into society and do extremely well. What are the challenges that we're going through right now? So number one, there's under-recognition of cancer by health workers and the community. There can be that abdominal distension that is ignored and ignored. We deworm and deworm and deworm, and yet it is a cancer that is growing. There could be that lymph node that just say, oh, maybe it is just tonsils, or maybe it is this, or maybe it is that, and yet it could be cancer, and yet we have just delayed in diagnosing it on time. So because of this under recognition, we get late presentation. And now when you have late presentation, the disease has spread to so many organs. And so it may be too late to be able to cure the child. So also the cost of diagnosis is a problem, because sometimes we've seen, like, for example, 50% of the cancers are leukemia and lymphomas of childhood cancers. And to be able to diagnose them very well, apart from the peripheral blood film, the hemogram, and the histology, we need immunohistochemistry or flow cytometry. We find that to get immunohistochemistry in a public hospital, apart from Moi Teaching and Referral Hospital and maybe KNH, is difficult. And so flow cytometry, I think it's only MTRH as a government hospital that is providing. And so you find that then the cost of diagnosis is too high. So if you're an outsider and you're not in that hospital, you have to pay a minimum of 14,000 shillings. And many parents cannot even afford that. So we need to avail these lab services in all county referral hospitals and subsidize the price so that it is available. And so that once you have the index of suspicion, you can confirm the diagnosis and the type of leukemia you're dealing with or the type of lymphoma that you're dealing with. And then you can start treatment in good time. And so cost of treatment is also a problem. We find that many county hospitals have not yet been registered as cancer centers, and so they don't get chemotherapy directly. You find that many times when the children are presenting to the county hospitals, they do not have NHIF at all. In fact, many of them have never heard of what NHIF is or what the benefits of NHIF are. And so you find that now you end up having to refer, and then when they are far away from home, they feel that they can't cope up with the treatment, and sometimes they can abandon the treatment halfway for a potential curable disease just because they feel that they're too far away from home. Then lack of blood products. We don't have enough blood products. Also the machines for making blood products, like the platelets, are very few, and sometimes they're not in good working order. They break down all the time. And so we say that leukemias are one of the most common cancers in children. So you need a lot of platelets, you need packed red blood cells, you may need fresh frozen plasma. And so we need a lot of these blood products. Then unfortunately in our setup, we also have a lot of malaria. We have a lot of iron deficiency anemia. So you find that children, we have also the PPH because of these anemias, even in the mothers. So we find that there's such a high demand for blood that you hardly have enough to be able to support children with cancer sufficiently. So that is another challenge that we go through. Then family disruption and strain. So especially if children have to be referred to faraway hospitals, many kilometers away from their home, you find there's a breakup of the family, there's the lack of income, there's strained relationships between the parents. And you can see even the siblings not being able to go to school because their parents are not earning. And so it is important for us, even in all our treatment centers, to be able to have daycare where the child can come for chemotherapy during the day and then go back home. And so that there's no need for prolonged hospital stay and prolonged separation from their homes. So that then lack of medical insurance, as we have said, most people have never even heard of NHIF in the first place, leave alone paid for the NHIF. And then shortage of health workers. We find in the county hospitals, we hardly have any medical officers, and the few workers that are there are under high strain. For example, I'm a pediatric hematologist and oncologist, but because of the shortage of staff, I still have to do a lot of general pediatrics as well. And so we are quite overwhelmed in the responsibilities that we have. We find for a ward of 100 children, you may have only 2 nurses on duty at any one particular time. And so they have to give, then we know that cancer children require a little bit more extra care. And the nurse has to take care of that cancer child as well as many other children with acute and chronic needs. So those are some of the challenges that we go through in the counties when we're dealing with children with cancer. Next, please. So what are some of the solutions to these challenges that we are talking about? Number one, this is what we're doing today as we're preparing to commemorate International Cancer Day tomorrow, the sensitization of the community and also health workers on childhood cancer. So make the message simple. You know, if you go to the community and you tell them about rhabdomyosarcoma and use very difficult words, it becomes very difficult. But when you tell them the simple things that if you see this change in the eye, it might be cancer. If you have a child who's having a headache all the time, it might be cancer. If the child has a swelling somewhere, it might be cancer. You give a very simple message. When you give the simple message, they will have a high index of suspicion. And when they come, do not dismiss them, listen to them, and take a careful history, do a good physical examination. You might actually discover it is cancer. And the few sessions we had with our outpatient staff, we were able to pick up so many cancers in children that had otherwise been ignored. And these children now are able to get their definitive treatment, and many of them have been cured. So the other thing is also to train training of health workers on childhood cancer, which we are doing today. Then provision of health insurance and comprehensive childhood cancer package. And we thank our previous speaker that the National Cancer Institute is working towards making that possible for all families. Cancer can affect any family. There doesn't even have to be a family history of cancer. So it will be so good if every family has the insurance in place so that if cancer comes about, there's no need to struggle. All the investigations can be done in good time. Referral, if need be, can be done in good time, and the child can get complete treatment with the package that the policymakers are designing for the children. So another thing is provision of chemotherapy and other treatment modalities. In the countries, we are really struggling because even basic drugs like Expen, ceftriaxone, artesunate are a big problem. Now, leave alone the cancer drugs and the antibiotics and antimicrobials that you need for good supportive care for cancer patients. So we really need to make sure that financing of the counties is improved and that there's ring fencing on money for funding for diseases, cancer included. And remember that children with cancer can get any other disease. They're not immune to malaria, they're not immune to pneumonia, they're not immune to tuberculosis and any other of the tropical diseases. So in Africa, we have to remember that we have a burden of non-communicable diseases together with communicable diseases at the same time. And so we need to just make sure that our health financing is enhanced. Currently, all counties are struggling. All counties are in debt, not even having enough money, even just for the basic drugs, leave alone these now extra drugs that we need in children with cancer. So we really need to be great advocates, to talk to the leaders, to talk to the politicians, that it cannot be business as usual. There is need to make sure there is ring-fenced funding and proper prioritization of health so that we can be able to treat these children rather than look at them and not have anything to treat them with and not be able to support them sufficiently. So we need to also have blood drives to ensure that there's sufficient blood products all the time. We need to make sure that all our blood banks are well equipped with machines that can make platelets, packed red blood cells, fresh frozen plasma, and all the blood products that we require. Then we need to employ sufficient health workers of all cadres so that these children can get proper 24-hour care whenever they're in the hospitals, and even when they come for daycare, they're able to be treated well and they can go back home when they are well. So as the previous speaker had said, it's multidisciplinary. And we need to work together as a team. It is teamwork. It cannot be the oncologist alone. You need the watchman who needs to make sure that the child is registered in time. We need the records clerk. We need the team in the mother-child health clinic. We need the laboratory staff. We need the pathologist. We need the radiation team, the people doing the ultrasounds. We need all of us to work together as a team for us to be successful. And as we had mentioned before, there's need for family support because cancer is very, very mentally draining and emotionally draining, even psychologically and spiritually draining. There are parents whose children have died who still call me many years after the children have died, and they still feel so sad and so drained. And so there's need for family support at the time of diagnosis, during the treatment, after the treatment, and even sometimes even after death of the child. So that said, there is hope. Next slide. There is hope at the end of the tunnel. There is light at the end of the tunnel. There's so much we can do, and this is the beginning. Once we begin to sensitize more and more health workers, we'll be able to diagnose these childhood cancers early enough, get them the right treatment, support them very well, and then follow them up now when they are survivors. And know we are going to have more and more survivors out there. Thank you so much for listening.
Thank you, Dr. Omedo. I think we've all learned a lot from that. I can see you're getting some flowers, some reactions. So I believe our team are very happy about your presentation. So as it has been previously mentioned, the theme for this year's International Childhood Cancer Day is that better survival is achievable through their hands. And we are focusing on the caregivers, the parents, the society that surrounds our children generally, and especially children being treated for cancer. So we have one parent whose child has been treated for cancer, who's going to just take us through the journey. How did it begin? What were the symptoms that they saw? How was the experience through the health system? What did they go through? What worked well? What did not work well? And just perhaps some insights that he can shed to us as we plan on the steps forward. So Stanley, you can unmute yourself. Can you hear me?
Stanley.
Yes, Cheriot.
Yeah.
Yes.
Yes,
tell me
I'm
if you
here.
can hear.
Yes, I'm hearing you.
Okay, all right. So maybe I can just take you through a few questions. You can just introduce yourself, tell us about how this journey started.
Okay. It was way back 2019. I'm Cheriot Kipkuru Stanley. I come from Bomet. So the story about my child started way back 2019 March. So the child was going to school. Then I received a call. The child is for meeting. He was for meeting. Then I took it to the hospital, and then it was given some antibiotics, and then they did H. pylori. Then we go back home, but the child continued with same story for meeting, and then start complaining about pain in the. There was a swelling on the right hillock for some swelling. So, and the swelling was very firm and non-tender. So after I saw the child was complaining about that, and then that thing was so hard. So I took him to Mother Hospital for FNA. And then after then, the results came out, and they told me there was disorders in keeping with non-Hodgkin's lymphoma. And then the doctor directed me to go to KNH. And then the child was admitted, and then he started the medication.
Okay, so has he finished the treatment?
Yeah, and then, hey, the journey is so long. It started way back 2019, and then, you know, this, but I'm telling, or I'm informing, I'm requesting the guardians or the parents having same story to follow the doctor's instruction, because if you don't follow the doctor's instruction, you believe like these people believing in superstition, the child was being bewitched, what, and then another mistake people are doing is they are mixing the dawa ya kienyeji, I may say so, with the one from the hospital. So I'm urging to you parents, please follow the doctor's instruction. So my child finished the 24 course on December 5th. So now the doctors are going on with evaluation. So far, everything is okay. So I'm waiting for the final thing to tell me.
Okay. And how about the cost of treatment? How are you able to meet the cost of treatment?
Really, there is a lot of financial constraints. NHIF really do help. And above all, I may say it is God grace. Because sometimes you may go the NHIF say, like the scan, they only allow only 2 or 1 in a financial year. So, and maybe the doctor has requested 1 or 3 or more scans. So you have to look for money out of your pocket.
Okay.
But 2020, there was a challenge since there were lockdown, and I think the child was in the ward, and then there was like I think they have to activate the NHIF or what, and then there was lockdown, and I was in up country, and the child was in. After, so I had to pay NHIF pay for after a financial year because it was from March to July. Then the others, then I had to pay. So it's really challenging financially. But anyway, you play your part and leave the rest to God. You believe it well.
Okay. Perhaps maybe you can tell us were the doctors supportive when you were in the hospital? Were they talking to you, talking to the child, to the other, like the mother and the siblings?
Yeah, the doctors, me, I was in Kenyatta, so the doctors were really, let's leave alone even the doctors, all the medic teams, right from even from the, how can I say, like housekeepers, like cleaners, what, they were really, in the ward I was, they were really supportive. So the whole panel, but to me, because I accept everything, and I say, yeah, doctors are like my parents, like my brother, sister. So they are supporting my child, and I accept everything. Really, they were really supportive. They are supportive. They are giving moral support, even encouraging the child. And the parents also. But to me, I just leave everything. I told them, no, you treat, Jesus heal, you play your part and leave the rest to God. Because anyway.
Okay. So currently you say the child is out of hospital. How is he doing? Is he energetic? Is he looking better?
He's better, yes. In fact, he's now turning 13 and he's supposed to join Form 1. So he's very healthy. Even the recent tests, they are all is good. HP is 14.6. So I'm seeing the health is okay. Because I also encourage the child, because if you other parents are saying, oh, you are so sick, so what? So like also demoralizing the child, so they don't get moral support from you. So we parents, you have to give moral support to the child.
Okay. So how did this the child continue with school while continuing with the treatment? How was that?
Yeah, that's another challenge because we used to come to the KNH like every 3 weeks. So the child was like only going for one month to school, then back to the hospital. Sometimes there was some things wrong, then he had to be admitted. So, but anyway, so we have to encourage. And mine was he sat for KCP. That's why I told you he's joining from 1 hour, and he really tried. He got 301. So he really tried. So you have to encourage so that he cannot get that stigma of being sick. Cancer is a killer. Who said cancer is a killer? Parents, cancer is not a killer disease. It's like normal other diseases. So we have to accept.
Okay. And maybe how did you get support from maybe the teachers, the church, the community around you? How was?
Yeah. My child is a church choir, and the school he was, that was Langata West. They really support. And my friends, even doctors, I really appreciate. Some doctors was calling me, Keep or Papa Adrian, how is the child? Then they send me something. So I really, when I told them, this I don't have for fruits, I don't have for this, and this, and then they really supporting me. Even after the others, they left Kenyatta, they go for others, but they really following up. They are calling me. Even others in the outside the country, they are calling me. Maybe they were in Kenyatta doing some masters, for example, the students which are intern, they still follow, they call me, and they really support me. So all medics, they really supporting me because anyway, when you accept and you don't give them rough time, you follow what they are telling you, then they are friendly, they are supportive. So sometimes parents, they are seeing the doctor is so harsh, but he's harsh because of what you are doing or what you are reacting. When the doctor tell me you do this and this and you are going against it, it's like you are killing that child. So you have to follow the instruction from the doctor.
Okay. Thank you, Cheruiyot. Maybe you can just leave us with the final word. Like, what would you tell the listeners as a parting shot?
To me, to doctors, I really appreciate the work they are doing, because I know doctors, medics, they are doing not from as profession, but it's a call from God. They are doing from their heart. And parents and guardians or caregivers, really give the patients moral support and don't discourage. And please don't mix the treatment with traditional one with the one from the hospital. Don't, please. And don't believe in this superstition, the child has been bewitched, you go for prayers. Anyway, you may pray for the child, but don't go. Other people are coming to pray for the child and you don't know what they are praying for. Maybe they are giving other motives or whatever to the child, other spirits, and you are believing. So leave the doctor do their part and leave the rest to God. That's all I have.
Okay, thank you for that. That was very insightful. We believe now we've heard from someone who's gone through the journey and how it was. So even the team is posting encouragement messages and saying they appreciate that you agreed to speak to us and to tell us about your child. So thank you for that. Dr. Irene, I think you're in the call. Maybe you can just follow up with what Cheruiyot has said and just highlight that journey from a doctor's perspective, just reinforce maybe some of the things that he has mentioned, and then we go to the questions.
Thank you, Joy Frida, and thank you, Dr. Omedo. Baba Adrian, thank you so much for sharing your journey. And yes, I totally endorse what he has said, and especially for highlighting the not mixing conventional therapy, which we are giving the children here, and other treatments, because you can never know how they interact with the chemotherapy. And so you're treating a child and they are not improving, you're giving the correct doses, the correct medication, until eventually the family comes to disclose that all along we've actually been giving this and that from KNH. Otherwise, the journey from the beginning, we've developed a culture in Kenyatta and also in the other places where we are treating children to start the journey with a family conference where it is open. There are no secrets anymore. We sit and discuss together the diagnosis and the journey of the child. We have experts now who disclose to the child their level of understanding, so that the child is a major partner in the journey of treatment. Once they understand why they have to keep coming back for chemo and why they have to do these infection control measures, compliance to treatment, these are the things that make a difference in the outcome. Maybe one challenge I would like to highlight is the issue on treatment abandonment or loss to follow-up. And I saw Dr. Lesan, our surgeon who is also on the forum, had raised it, that we still struggle a lot with patients who get lost to follow-up, and we are not having a navigation system for children. We need patient navigators who are totally dedicated to pediatrics to ensure these patients can be navigated from chemotherapy, from one clinic to the other, to radiotherapy, to surgery. Then after surgery, they are back, and they don't get lost in the whole system. And also when they struggle through a lot of the challenges that they go through, we want to make sure that somehow they are able to follow through their treatment to the end. I'm so glad for Adrian because now he's at the end and we are doing an end of treatment evaluation. So I would like to say it's a partnership for us as the doctors who are treating and all other health workers, together with the patient and the family and the other supportive services. So if we work together, childhood cancer is curable and we'll be able to achieve much together. So thank you very much. Those are my comments.
Okay, thank you, Dr. Irene. Dr. Irene is part of the technical group in the Ministry of Health that advises the ministry on the intervention to undertake the policies that we need to develop in terms of childhood cancer. So you can be sure the ministry is receiving all this feedback. There's someone who's asking, Dr. Medo, what is the survival rate in Kisii since the diagnosis, 1 year versus 5-year survival? Are you able to answer that?
Okay, so we've not had very many patients because we just started recently, and we've also been having many challenges because, for example, we don't have a chemotherapy hood, so we've not been recognized officially by NCI, and many other challenges. Sometimes we end up having to refer even children who we could handle away. But we do have a few cases that we have had within our county. There's one stage 3 Burkitt's lymphoma who had come with acute kidney injury. He went through the chemotherapy. We used the MTRH protocol, and now he's been in remission. He's doing well. We have 2 cases of acute lymphoblastic leukemia T-cell. One for a teenager and another one in a younger child who was around 3 years when we diagnosed him. They are all now going through their long-term therapy. 2 years down the line, they are still in remission, continuing the maintenance chemotherapy, and they're doing well. But there's some also who we lost. We had a neuroblastoma who came in stage 4. He did well. He finished the chemotherapy, had a good quality of life for about 2 years. But unfortunately, because he had presented very late, and there are so many other advanced treatments that we could not give in our country, including stem cell replacement and therapy, we ended up losing him. But we're still in touch with the parents. We still follow their family up even after death, making sure that they're okay and that they're getting the psychological and emotional support that they require. Then many others, we've been working in collaboration with KTRH, with MTRH. So sometimes some children go for treatment there, But when they fall sick, they have neutropenia or they're anemic or they have low platelets, they come to KNH, to KTRH, that's Kisii Teaching and Referral Hospital, and we give them support as they continue with the chemotherapy from the other end. We've had many patients even from Kenyatta who started treatment there, and then we've continued with them from this other side. So we are still young. We can't even say that we have started. I still feel like we have not started officially. There's so many deficits, but the few that we're able to get and we are able to avail the chemotherapy, we do treat. But where we are not able, we refer, but we offer support throughout. Thank you.
Okay, thank you, Dr. Omedo. Maybe Dr. Irene, there's a question about cases of childhood cancer from Western Kenya. Apparently there seems to be a lot of cases from that end. Is that true? Are you able to substantiate that comment?
Thank you for that. I think we would need to really look at the data. With an analysis that's based on where the patient comes from. Maybe I can say, because I'm in KNH, maybe I've not observed that. But what I realized is that because this is a referral hospital and the patients are from everywhere, it's seasonal. There's a time we had a lot of patients from the Somali community. In fact, almost like a third of the ward, like 30-35% of the children in our ward were from the Somali community. Then a time came, we had a lot of children from the Kamba community. Another time it was seasonal, we had these ones from Western and Luo Nyanza. And so I would say I cannot authoritatively say that it is true. Maybe we need to take time and analyze our data based on the ethnic areas people come from, and we combine the data nationally. We see what KTRH, Kisii, and the other centers are seeing to be able to say there's too much child impact. Thank you.
Okay. There's another question, Dr. Irene, about cancer spread after biopsy or tumor seeding. They're requesting you talk a bit on that.
Okay. What is clear that cancer is a physiological issue.
Sorry, Doc, we seem to not be getting you clearly.
Sorry, I'm on the road. Can you hear me now? Sorry, I'm on the road. Is it any better?
Yeah, that's better.
Sorry, because I'm speaking from the road. I wanted to say that cancer diagnosis is really a tissue diagnosis, especially for the solid tumors. And so having a histological diagnosis through biopsy is very important. Now, there are several ways you can do biopsy. For the ones where you can have an excision, where the mass was and an excisional biopsy can be done, you can remove the whole swelling and have it checked in the lab. So you still get your diagnosis, whether benign or malignant, and the tissue is out. But for tumors that are so huge and excisional biopsy is not possible, it is okay to do image-guided biopsy or even to do a true cut, because you must have the correct histological diagnosis to be able to treat with the correct protocol. Many childhood cancers look the same. They call them small round blue cell tumors. Now, there's one cancer in children, Wilms tumor, where we treat without doing a biopsy, except in some exceptional situations. This one, we can easily make a diagnosis by imaging through the CT scans and such treatment. So when the children now go for nephrectomy, when the kidney is removed, that is when we get histological diagnosis. So let's not the fear of doing a biopsy in a child with a solid tumor that is suspected deny us the opportunity of making an early diagnosis, because what you need is to diagnose early and treat early. Thank you.
Okay, Dr. Irene, so the question was about cancer spreading after the biopsy. What do you have to say about that?
Yes, there has always been that concern about seeding or about tumor spread. particularly with lymphomas. These are the hematological malignancies. But again, if you look at the literature, you will find papers in favor for both. You will find there is evidence and there's also no evidence for it. And so as much as you have a risk that when you do a biopsy, within that period of time, it takes about a week to 10 days to get your histology report back, that there could be some local seeding. Remember, you're taking a biopsy within the tumor, inside the tumor itself. And so a lot of times the papers we've come across have shown that there's very minimal risk of seeding when the biopsy is done correctly by the correct specialist. Poking everywhere blindly in the abdomen, and it's done correctly and professionally, the risk is very minimal. Thank you.
Okay, thank you. Dr. Deborah, I'm seeing there's a question about the follow-up for families and for the families of children on treatment. Someone is asking, do you have dedicated patient navigators and who takes care of that cost?
So we have a palliative care team consisting of some clinical officers and also some nurses who have been trained in pediatric palliative care. We also have a few nurse psychologists who have been trained in psychology as well, and a few other non-medical psychologists attached to the hospital. So it depends on case-by-case basis. So even long after the patient may have died, the family can still come in for support, psychological support, spiritual support. We have also a hospital chaplain. So we are able to kind of give them the counseling and the bereavement counseling and psychological care. So that is one of the things that we are able to do. So they just come and we continue with the treatment. We have a palliative care. We have a former Ward 5. That's why we have the palliative care unit. We have even a radiologist based there, and they're able now to come from time to time on a need-be basis for just that support. Sometimes we have our nurse psychologists doing phone consultations because some of them come from far. Like we have a patient who came all the way from the Tanzania border, and they can have phone consultations with them as well. So every family is different. There are some who will want to come frequently. There are others who just want a phone call and just talking to you for a short time. Every case is a bit different. Yeah. So that is some of the care that we're able to provide.
Okay. Then maybe you can speak about the survival rate in childhood cancer. We've said the survival rate is a bit low. So there's a question about how do we work out this survival rate? How do we calculate it? And is it different from that of adults?
So, okay, I'm sure the statisticians may be better than me in being able to count the survival rate, because you want to see how many, you want to find out how long they are in remission after they have been found to be in remission. So the 5-year survival rate, how is it? So you need a big number of patients. So unlike KNH and MTRH, we don't have that large number yet. We just still are having a few trickling in because many times we have to refer out. So, but we are fortunate in our hospital. We have electronic data. All our outpatients is completely paperless. So if we work together with our records clerk and the palliative care team who have all the files of the patients, I think they can be able to calculate the survival rate. But for the individual patients that we're following up, there are those who have gone into remission, and those who are still on follow-up, continuing with their long-term management.
Okay, thank you. So we had spoken a bit about the role of palliative care, even in these childhood cancer cases. I don't know if Dr. Irene is able. Dr. Irene, are you able to maybe just highlight what the pediatric palliative team at KNH do for these children?
Yes, Joy Frida. So we work very closely with the palliative care team. They take care of both pediatrics, and they also extend their service even to the adult side of oncology. But for us, we walk the journey from diagnosis with them. So from the moment we are already at diagnosis, giving that family conference, discussing the diagnosis, what to expect, there's a lot of tears and denial initially, and family needs to come to terms with this. We are always with the members of the palliative team, and then they start this journey together with this family. And so apart from pain control, which is in their docket, and they do very well supporting us to make sure our children are pain-free, they also keep coming during the ward rounds. We can be able to do rounds together. And they don't only review the dying children. So the perspective has changed. It is from diagnosis, because a child has a life-limiting or a life-threatening illness. So there are those ones who are well, but because it's a cancer journey, the palliative team still visits them. Our patients who are dying are in very good hands with this palliative team, and they've also been able to create a network. So from KNH, we can down refer children who are dying, and we want them to go closer home, and the family is spiritually, psychologically prepared. Our palliative team links them up with the other palliative team in the counties or in the districts, in the village, and they continue following up even after the patient has died, like Deborah said, for bereavement counseling, but this is only on phone. So I would say they really play an important role, and it's important to always include them from diagnosis. Let's not be calling them only when we see this patient has deteriorated and is dying. Thank you.
Okay, thank you. I know MTRH have a program where they use, I think it's called play therapy. They've previously informed us that they have a very robust therapy for children, where the children really do a lot of art therapy. They even do some album about perhaps the things they'd like to do in life. And even when their prognosis is not very good, they're able to be explained too well, and they're able to even be told to prepare just a history of their life, like what would they want to be remembered for. And I know in the Kenyan culture, maybe such things are a bit awkward, yeah, but I think we are seeing this palliative team really bringing the hard conversations to the front, so that we are able to handle this thing even when the child is still here, and the whole family is able to be assisted to process this difficult disease, this difficult outcome, which is very essential. So I'm seeing there's a question about NGOs that support poor families in case of cancer treatment. From my end, I know there's Hope for Cancer Kids as one of the organizations. We also have Faraja Cancer Support Group that supports a lot of patients in KNH. But I know you can find more information on the KENCO website. KENCO is Kenya Network of Cancer Organizations. So you can find more organizations that that support families with cancer treatment. Okay, I think we've handled all the questions. There's a question about if old patients return to give their experiences on treatment or care. Dr. Irene, I know KNH have been doing this for a longer time. So do you have patients coming back, and do you use them maybe to encourage the other patients as they're undergoing the treatment?
Yes, Jeffrida, we do, because we do have a survivorship program. It's not like a registered program, but you can call it a survivorship clinic, because we never totally get rid of our patients. We still see them even once a year, just to be sure they are well. And what I've realized is once they have walked through that journey of childhood cancer and they survive and they recover, they are always willing to come back to our oncology wards. They actually visit, they come sing for the children, they bring anything, they bring toys, they bring books. When we have an event, we call some of our survivors to come and speak to the families and the children to encourage them from the point of view that I have been there, I got the chemo, I got the surgery, and now I'm here, I'm back to school. So yes, we do have success stories with survivors who are always willing to come back and support our patients. Maybe what we don't have is like a registered survivorship program inside the hospital. Thank you.
Okay, thank you. Thank you for that. So perhaps we can just go to the closing remarks. Dr. Medo, you can go first. What would be your passing remarks as we end the webinar and just towards the International Childhood Cancer Day?
So I want to thank the National Cancer Institute for such an initiative and for the deliberate move to include childhood cancer, which had been for many decades been forgotten or underlooked. And we need to strengthen the counties. We need to strengthen the counties. That's what I can ask for. Let the counties be strengthened to be able to make accurate diagnosis and to be able to offer the treatment and support. That way these children can get treatment nearer their homes and they can be easily integrated back into school. Yeah, so that is what I would plead with our governments and all concerned stakeholders. Let us strengthen the county referral hospitals to be able to offer quality diagnosis, treatment, and support to children with cancer. Thank you.
Okay, thank you, Dr. Amedo. Dr. Irene, your parting remarks.
Thank you, Jeffrida. I'll also echo Dr. Omedo's comments. As I support that, I just want to add that each of us, it's our business. I love saying that. It's everybody's business. Childhood cancer, any child in Kenya who has cancer is our business and is our concern. So I'm so glad all of us who are here today, this awareness, trying to detect them early. We have more webinars this week, please join. There's one on Thursday by Kenya Society of Hematology and Oncology. And every day where you are, just be on the lookout for these children because you could be the hands that God is going to use to touch the life of that child. So my parting shot is that it's everyone's business, childhood cancer. We can make a difference if we all participate. Thank you.
Okay, thank you so much. So I think we've come to the end of our webinar. KNH Research Office, do you have any announcements? Nelson and Tim. Okay, so we'll end it at that. Thank you all so much for joining us to commemorate the International Childhood Cancer Day. So tomorrow, remember to tell everyone that International Childhood Cancer Day is on 15th of February. And since we're in the month of love, let's love our children enough to get them quality health, prompt health when they need it. And we support all our patients who are going through this process. They may be referred down to you for supportive management. Let's be kind to them. Let's be supportive to their parents. Let's create awareness even among the teachers, among the religious leaders, so that even when they are bringing in the prayers, we are not stopping the medicine that the child is going through. So thank you all so much for availing yourself for this meeting. The CPD points will be sent to you on email. So thank you to Dr. Medo and Dr. Irene for all your inputs. Until next time, have a good afternoon.